Hospital. She works in clinical research near where I used to work, so upstairs from where I worked. And for Department of Endocrinology. And Jo's been a diabetes educator for a long time. How many years?
A long time. 9 years.
And spends a lot of time educating diabetic patients on, particularly new medications that are coming on the market.
Yeah.
And I think we're really fortunate to have her here today to present to you guys about diabetes and give a bit of a different perspective.
So do you have to be a nurse to be an educator?
No. You can be a dietitian. Yeah.
So are you a nurse?
I'm a nurse. Yeah.
Take a seat. I'll
Yeah.
let you get on with it.
Yeah, no worries. So I'll give you a little bit, just to start with, I know you're all about to become nurses, so probably just a little bit of background of my nursing career, because I think that's always interesting when you're just about to embark on it, and it's a really wide array of areas that you can get involved in. So I trained at Deakin Uni in Melbourne and did my grad year at the Epworth Hospital, so in the areas of oncology, a little bit of surgical and some cardiology, and then I came down to Geelong and met my husband, and I did a bit of work. I've done a whole lot of nursing work in all different areas, so I worked in a radiology department for a little while still on the wards. I worked a few years at St John of God on the urology and vascular ward over there, and then I had my first son, and while I was off with my first son, I just thought I might want to do a bit more further education. And I kind of knew already at that stage of my nursing career that the patient education and talking with the patients was probably what I liked best rather than the task side of nursing. So it was more about that human side. So I went down an education role and did a diabetes education postgrad. And then I went straight from that role into the clinical trial unit at the hospital. So the clinical trial unit there in endocrinology, like Cherie said, we work in sort of newer therapies, so diabetes medications that either are just on the market and they would like to just follow a whole lot of people who are taking that medication for a long period of time, or medications that are a little bit prior to that. So they know the safety side of it, they kind of know the side effects, but they just want a specific target population, and people volunteer and they come in, and then we see them regularly over a period of time, and a lot of that time that we spend with them is education on their diabetes management and the new medications and things like that. So at the moment I've got a type 1 diabetes study that's using a pump, which is really great because it's sort of a newer area for me. I haven't had that much experience with pumps. Our type 1 studies have just been using insulin in pens. So as my career goes on, I'm still learning every day as well. So this was good for me to kind of recap on those little earlier things with the diabetes. So I might be overlapping a little bit of what you've already done. So I hope not too much, and I hope there's a few little things in here that are new to you, or you might take something away. So I've got a bit of practical stuff as well as some brainstorming, and so sort of some practical and then some information to sort of take on board. So we'll just start diabetes and how your nursing approach can directly impact diabetes management. So I think you've just gone over this morning. So there's the main two types. There's a couple of other areas within diabetes with gestational diabetes, which is diabetes diagnosed when you're pregnant. So, but the main two are type 1, which is an autoimmune, so it's where the immune system attacks the pancreatic beta cells and you can no longer produce insulin, is basically the crux of it. It's usually an abrupt onset, so you have symptoms that bring you into hospital, and they can be increased thirst, needing to go to the toilet, weight loss, irritability, fatigue and blurred vision. It's most commonly diagnosed in children or young adults, although there are some older adults that are getting diagnosed of more recent years. And the treatment is insulin. So you will need insulin to treat eventually. There is a little bit of a talk. Sometimes when you first get diagnosed with a type 1 diabetes, the pancreatic beta cells still have some function. So you have a period of time where you may not need insulin, and they call this, you might hear, a honeymoon period. So sometimes there's a honeymoon period before you start to need to use insulin. And more recently there has been some use of oral diabetes medications in conjunction with insulin in type 1 diabetes. So type 2 diabetes, it's related more to ageing, family history and lifestyle factors. And it's usually diagnosed through an elevated fasting blood glucose. There's a resistance to insulin, so your pancreas still produces the insulin but the body doesn't use it as well as it previously has, or it does not produce enough. So it's a combination of both. And the treatment is usually initially some healthy eating, exercise and weight control, and if that doesn't help to sort of bring that fasting blood glucose down, then tablets and insulin may also be required. So, just for me to get an understanding of where you guys are at with diabetes, can we just do a little bit of brainstorming? So just some words that you would use that are sort of associated with diabetes. So I'll start. So if we do this. So I would say some common words would be sugar. Anybody got any others?
BGI.
Yeah. Sometimes they call that BSL as well. You might hear that too. Exercise. Oh. Help with all my spelling now. Insulin. What about, has anybody got any family who have got diabetes? No? What about, have you heard the word chronic? So sometimes it's long term. Yeah. Food. Choices. What about, have you heard carbohydrate? Have you spoken about carbohydrate? Yeah.
Ketones.
Yeah.
Ulcers.
Yeah.
Your finger pricks.
Yep. Very good.
Pumps.
Yep.
Then like you've got your symptoms like excessive thirst.
Yeah. There's a new it's Diabetes Week, National Diabetes Week next week. This week it's the 19th to the 24th, so there'll be heaps of information that's coming out, and there's a good one on the symptoms. They're calling it the 4 T's. Yeah, it's good, like simplifying it all. I'll just write symptoms down here too. What about when we think of the difference between type 1 and type 2 in terms of people, do you have any sort of visions in your head when it comes to thinking of somebody with type 2 diabetes? And words you would... Yeah?
Their lifestyle choices.
Yeah.
Sedentary.
Yeah.
Sedentary.
Oh, Terry. Terry? A-R-Y?
We don't correct it, we don't know.
Is that right? Don't take that bit. What was the other word? Did somebody say another word?
I said lifestyle.
Lifestyle. Yes, it's good. Well done. Alright, so we'll just leave that there for a minute. Right, so I'll just talk a little bit type 2 management, and I'll tell you why we'll spend a little bit of time on this. So there's a big focus on early detection and intervention with type 2 diabetes. Usually, and the big question, I guess, is why is that? Why does it need to have early detection and intervention? Sorry, it might be a bit low. So the prevalence of diabetes, based on self-reported data, tripled between 1989 and 1990, and to 2014 and 15, with the proportion of people living with diabetes increasing from 1.5 to 4.7%. And so you need to keep in mind at the same time that the Australian Institute of Health and Welfare data also suggested that 1 in 5 adults with type 2 diabetes remain undiagnosed and untreated. So the usual time frame is 7 years that somebody may have diabetes and not know. And so that's why there's a whole lot of drive for people to have early detection and take some time. So it's difficult to estimate the exact number of people, but it's likely more than 1.7 million Australians are living with the disease. And it accounts for approximately 85% of the people with diabetes. So type 2 is a big proportion of the diabetes, people living with diabetes. So in 2015 and 16, 50,000 hospitalisations with diabetes as the principal diagnosis. That's huge. Yeah? And of these hospitalisations, 29% were type 1 and 63% were type 2 diabetes. Over 1 million hospitalisations with diabetes as an additional diagnosis. So they've got a coexisting condition, and then with the principal diagnosis, or a condition arising during hospitalisation that affects their management. So 90% were type 2 diabetes. The Diabetes Australia website estimates that the total annual cost impact of diabetes in Australia is $14.6 billion.
So you're an important resource.
Yeah.
Going into the future.
Yeah.
So we're taking note of that.
Yeah. Yeah, it is. So
yeah, that's right.
it pushed it pushed a strategy basically for 2016 to 2020, and these are the main goals. So the goal 1 is to prevent people from developing type 2 diabetes. It's also a goal to promote awareness and earlier detection of type 1 and type 2 diabetes, so getting those symptoms out there, or the risk factors out there. Reduce the occurrence of diabetes-related complications, and therefore you improve the quality of life. And so this strategy has driven a lot of health promotion activities by Diabetes Australia, and their main aim is to increase awareness and encouraging early testing and diagnosis of type 2 diabetes. And the real end result is our aim is to reduce the occurrence of diabetes-related complications. So the earlier you get treatment, the earlier you get diagnosed, the less likely you are to have ongoing related complications. And then how do all these goals and activities translate to the nursing care that we provide? So the key areas for optimum management, so this is sort of the loose, sort of as a diabetes educator, what we would be advising people. So with their diet, so we advise eating according to the Australian dietary guidelines. Many, many years ago, there was a bit of a push where people with diabetes weren't allowed to have any sugar or any, anything that was deemed unhealthy. And it's a little bit different to that, especially in type 1, which we'll go into a little bit later. But it's more about just eating a well-balanced diet. And then obviously the professionals within this diet are dietitians, much more knowledgeable in that area than what I am, so I would always refer people to see them. A body mass index, so you always want, if there's a need, 5 to 10% weight loss for people who are overweight. It can be a difficult parameter to standardise between different populations groups. Physical activity, 30 minutes of moderate physical activity on most, not all days. Obviously that's age related as well. And then the ones in green are the ones that we'll talk about in a little bit more detail today. So blood glucose level, 6 to 8 fasting and 6 to 10 postprandial is a word that you might hear. So that just means after a meal. The HbA1c, so this needs individualisation according to patient circumstances, but generally the 2 different levels are there. We used to just go by this this level, so the percentage, 7%, but America and other countries use the millimole per mole. So sometimes you will see that bandied around as well. It's exactly the same measurement, just like same number in terms of, but just a different way of measuring it. So less than 7.
Jo, do you mind explaining the difference between VGL and HbA1c?
I've got it in a bit, yeah.
Right.
We'll do the difference, we'll look at them differently together, yeah. And then there is the Australian Diabetes Society. So this is the algorithm for type 2 diabetes medication. So it's like saying initially you'll get diagnosed, and we'll go into that a little bit more. You have diagnosed, you have a time period where they might let you try and lose some weight or do some lifestyle change. And then if your blood sugar level is still sitting higher, they'll initiate some therapy, and there's an algorithm that they go down with that therapy, because there's loads of diabetes medications around. So there's sort of a way that GPs, and it's standardised across Australia, how they will prescribe diabetes medication while one person's on one tablet and another person's on insulin. Is a lot to do with that algorithm. So these are the three that we'll look at. Why do we monitor it? So a blood glucose level control enables the person with diabetes the best defence to reduce the chances of developing complications. So it gives them a number. So they at home, outside of medical care, can prick their finger and get a level, and then they can see change. So they could see if for, usually their blood sugar level when they prick in the morning is 6 when they're fasting, and then all of a sudden in 2 months' time it starts creeping up to 7, and then in 2 months' time it's up to 8. Then it gives them an indication of being able to go, 3 months ago I was sitting at 6, now I'm sitting at 8, maybe I need to go back to my doctor and just have a little check of how my blood sugar level's going. So it's a way that you can measure outside of sort of GP care, understanding what your blood sugar level is. So hypoglycemia is in a long-term, uncontrolled blood glucose level setting can cause complications. So if you sit at a really high blood sugar level, it's like the body has a little sense of, this is where I'm comfortable and everything's working really well. And if you sit outside that on a high level, everything in the body starts working a little bit extra. So this is how I explain it to people sort of when we're talking about it, is you have this nice comfortable level, and then you sit at a level where you're having to do a whole lot extra work. And by doing that whole lot extra work, you're overworking all the body's organs. So that when eventually, over time, if you sit at that level over time, they'll stop working effectively. So it's an easy way to kind of, so it's hypoglycemia over a long period of time can cause complications. Hypoglycemia when you're just unwell, or for a couple of months or a day, won't cause those long-term complications. So it's that 7 years where you don't know where you've got the diabetes and your blood sugar level might be sitting sort of a little bit higher. It's a very silent condition. So blood vessel damage, I think you would have gone over this today, not yet. Nerve damage, kidney damage, eyes, feet, non-healing wounds, so the ulcers, and tooth and gum infections. So target range can differ depending on age, duration of diabetes and the medications that are being taken, but in general, normal blood glucose levels are between 4 and 7.8, and we target 6 to 8 before meals and 6 to 10 if taken within 2 hours after eating a meal. If you take your blood sugar level, or somebody takes their blood sugar level half an hour after they've eaten pasta, and they're like, oh my gosh, my blood sugar level's 12, that's expected because it's got carbohydrate in it. If it's still 12 at the 3 hour mark and they haven't had anything else, then that can be an indication that maybe their body's not sort of converting the sugar as well as it can be. So people with living with diabetes who are experiencing blood glucose levels greater than normal or target levels on a regular basis may benefit from a review in their current diabetes management. This is what you'll see in the hospital. Have you got a kit like this here? So this is like a hospital, so on a ward, this is the blood glucose machine. These will be the little test strips that you put in the machine. This is control solution, so to test to make sure that the blood sugar levels are, that the test strips are getting the right level and it's accurate. And these are once use. So you wouldn't use a pen, you would use a disposable once use finger prick, and then a cotton wool ball for after if a little drop of blood. And this is what a home test. So the main difference with a home test is that they would just use a pen-like device and a lancet. You'll probably find that they say they use the lancet over and over again. Yeah. It's a good idea to change it, and not because they're their own decider of what they do, but it blunts off, so it hurts more. So it'll still give you a blood prick, but it'll just be painful. So timing, when do you take it? So the amount of blood glucose testing and the timing of testing can differ between people, and it's largely dependent on the medications that they use. And we'll look at insulin a little bit later, but you need to take it more with insulin because insulin drops your blood sugar level. Some of the other tablets just enable the body to use its own mechanism, so just use its own insulin a little bit better, be less resistant. So some of the oral medications, they might just be on a routine, random blood sugar fasting level, 2 or 3 times a week. But somebody who's on insulin would need to take it every time they're about to give their insulin, so they know how much to give. So the routine testing are pre-meals and before bed. Somebody who's just on an oral medication, you usually get them to just take pre-breakfast because we know that that's a fasting level. Sometimes the pre-meals ones, you could have had a morning tea at 10 and then lunch at 12. So sometimes you just don't get that break in between the time that you need to have a true fasting level. Other times that you might come across being taken, especially when in hospital and someone's unwell, would be overnight, so around about that 3 o'clock mark. Sometimes we take that because if they're giving insulin of an evening, so before their dinner or before they go to bed, it's a good idea to see what their blood sugar level is doing overnight, so to see whether or not, sometimes people can have a low, a hypo, and they recover themselves, and so you don't capture it. They might just have some really weird patterns, and so you're not quite sure what's happening overnight. So sometimes we direct people to take one in the middle of the night, just so that we can gather, it's about gathering information. And 2 hour post meals is that one, so we can see how well the body is dealing with the meal that it's taken, that it's just eaten. So Barwon Health has a prompt document, which is like our library of how you do things on the ward, and so that has the guidelines of when to test and why when you're on hospital. So you would find that probably in their patient notes. Hypos, sometimes called a hypo or low. It's a condition that occurs when a person's blood glucose level has dropped too low. Usually we class it as anything below 4 or 3.9. And it's important to treat the hypo quickly to stop the blood glucose falling even lower, and then the person becomes really unwell. Hypoglycemia can make it really hard to concentrate and carry out everyday activities. So we always say if you're about to drive and especially if you're on insulin, that you have to be above 5 to drive, is the saying. So people should be testing their blood sugar levels to make sure that they're above 5 before they get in the car. So it's much more common in people who take insulin or certain other glucose lowering tablets, but it can occur in people with diabetes who are not using insulin, but much more common when someone's on insulin. I think I asked this. Do we know the signs? Can I?
Is that board on the still on ahead? Oh,
That's
use
alright,
that.
I'll just move some of these. I just
Use
want to
that
keep
one there,
these
Jo.
on. Oh yeah. Have you gone through some signs and symptoms of, has anybody seen someone have a hypo?
Maybe dizzy.
Yeah. Dizzy?
Yes.
Sweaty.
You know your stuff. Anything else?
Cold.
Cold? Yeah. Everyone can be a little bit different too.
Unconscious.
Yes. Some people say trembly. People use, some people get hungry.
Would you be like pale and cleanse?
Good job.
I find it very hard to walk, like the legs
Yes.
go like jelly.
Uncle, yeah.
Yeah.
Yeah, that's good. I think you've got a few more than what. Shaky, trembling, weakness, paleness, hunger, mood change. Sometimes you can just tell. Like a lot of people will report back and say, "Oh, my wife can just tell when I'm about to have a hypo." I just change the way that I speak. Yeah. Sweating, headache, pins and needles, lightheadedness, dizziness. If it continues to drop, there's some more serious signs and symptoms. So later signs and symptoms can be concentration, confusion, slurred speech, not able to treat their own hypo, so they need somebody else to give them a hand. So they can't drink or swallow, they can't follow instructions, there's a loss of consciousness, and there's a fitting or seizure. Yeah, so that's, these ones here really are probably ambulance. Sometimes people will have they'll have a pen at home that they can use, but you would just call the ambulance and get them there as quick as you can. I had an occasion very early in my career as a nurse and a diabetes educator where out of hours I was dropping my husband at a pub, and there was somebody in a car in front of us who was sitting in her car, and my husband got out and he came back and he said to me, "I think she's drunk," and so he sent me over. And I so weird. And I was like, circumstances at a pub, exactly right. And she was an older woman, and we had a conversation. And then I said, "Are you diabetic? Do you have diabetes?" And she said yes. And she was having a hypo, and she didn't want to have. So we got her in, and she had a soft drink, but she didn't. She knew that she was about to have one, and she didn't want to have one in front of her friends. So she thought, "I'll just try and get home, and get safe." And so. It's always, like it's that catch-22. They can be symptoms that can be really misconstrued. So it is important that you kind of just have it in the back of your mind, all these symptoms that, especially out in society as well. Because sometimes they can come on quickly, the hypos, and sometimes people don't preempt them as well. What else have we got? So this is how we would educate somebody with a hypo. If they came in to sort of see us. So you check your BGL. If you can't, then you just treat it as a hypo. So if you get any of those symptoms where they, like somebody would think that maybe they're about to have a hypo, just treat it as one. Yep. So if you take a test and it's below 4, the first step is to have 15 grams of fast-acting carbohydrate. So this is where we talk about jelly beans, barley sugars, soft drink. So just because a lot of the time people who are living with diabetes, they might have things like diet cordial at home, so they're trying to do the right thing, but they do need to have the soft drink or the cordial that is going to have the sugar in it, because that's what brings their blood sugar level up. So fruit juice, honey or sugar, or there's the glucose tablets. So 15 grams of carbohydrate, and then we get them to wait. So just quietly wait. Recheck your blood glucose level to see if it's risen above 4. If it has, then we go to step 3. If it hasn't, you go back and you treat with 15 more grams. So sometimes where people with diabetes may, it's not get into trouble, but they may not wait the 15 minutes, which is fine, and it's just about keeping them, the person safe. But they may give more than 15 grams, so they may give 100 grams of carbohydrate, and then their blood sugar level goes really high, and then they have to manage the high blood sugar level. So 15 grams first, wait another 15 grams rather than 100 grams, and then have to manage the really high blood sugar level. So when they're over 4, So step 3 would then be to have some carbohydrate that's a bit more long acting, that's going to keep their blood sugar level up there. So they're things like bread, milk, dried apricots and those sorts of things, some yogurt, or a meal, if they're coming into a meal. Sometimes the reasoning behind this too can be, so sometimes a reason for hypoglycemia can be, especially when you're using insulin, that they've given a little bit too much insulin. And the hard thing with insulin is that it keeps working irrespective of what you do. So once it's in your system, it will do its job to its best ability, and then you have to counteract that with this stuff here. So that's why we always get you to have, this gets used up really quickly, energy-wise, so to have some energy that's going to keep your blood sugar level up a little bit higher. So I've got a scenario for you. You can talk to the person beside you. So Shirley's a 73-year-old woman with type 2 diabetes who was admitted to the hospital yesterday afternoon following a fall in her backyard which required surgery late last night for a fractured ankle. Shirley's medications for her diabetes include insulin twice a day, which she had a dose administered last night with some sandwiches at 23:30 hours, so that's 11:30 at night, when she returned to the ward. Following handover, you go in to introduce yourself to Shirley. She appears in quite good spirits and states that she has no discomfort in her ankle and is looking forward to having some breakfast, as she is usually an early riser and tends to eat breakfast as early as 5 o'clock in the morning. Shirley does mention that she is feeling a little dizzy and sweaty. Upon looking at her observation chart, you notice that at 600 hours her blood sugar level was 4.5. What would your next step be? There's no right or wrong answer.
Or a cup of tea with sugar.
Yeah.
They had a breakfast.
Beautiful. What could something be that you could do? So, who said that? Yeah. Check her blood sugar level. Yeah. So there's no limit to how many times you can check a blood sugar level, and it's good to have the information. So we check Shirley's blood sugar level, and it's 3.5, and breakfast is still 20 minutes away. So what could you do next? Tea with sugar?
Yeah.
Yep. Jelly beans. There will always be something sugary around the board. So we would treat. Actually, let's go back from that. So we would treat, and then what would we do in 15 minutes? Check her level. So we've got 20 minutes till breakfast, so that takes us, so breakfast is still 5 minutes away. If her blood sugar level was still under 4, can you remember what you would do?
You go back to
Give her more? Yeah. And if it was just above, then she would just have breakfast. Yeah. So if someone's had a hypo, I would also then tell them if they were to recheck again in a couple of hours. The more testing they do, the more safe they are. So then I would say, say Shirley, so her blood sugar level was 3.9, 15 minutes later. She had a little bit more sugar, then she had her breakfast. 2 hours later, I would just double check that her blood sugar level is in a good range, or a range that kept her safe. If we looked at this situation, can you pick out some things that may have contributed to that low? There's a few little things in here that probably
she eats so early in the morning is the later
She has the
time.
insulin.
Yeah, so she delayed her breakfast. So she usually has her breakfast at 5, and so she's delayed. She's got a couple of extra hours in there where she would have usually had something to eat. And her blood sugar, remembering that her blood sugar level, her insulin level, would have been what she would usually. So I probably should have put that in. So her insulin level is determined on her everyday activity. So there's some different activity in there as well.
She's fasting yesterday.
She was fasting yesterday. Yeah. So she was fasting. She had a different presentation or routine. And the other thing that can impact blood sugar levels that we haven't really spoken about is stress and anxiety. So sometimes those sort of things too can have a direct impact on what someone's blood sugar level does. So if you came into a handover where someone had been fasting the day before and was using insulin, they're two things that you would then go and see. The first thing that you should go and do is check what their blood sugar level is. Yeah. Two things that would impact it. So some advice to me in these situations as well. Always remember that your patient lives with their diabetes every day, and they're bound to be a wonderful source of information. Ask them questions. Yeah, especially if you haven't got any experience with anybody in your life. But it's also very important that our care is patient-centred and that we create an environment where patients continue to play an active role in their own diabetes management. And this includes being part of the discussion. So I would always start with this sentence. Your BGL is currently 3.5. What would you do if you were at home? Yeah, so enable them to be part of the treatment and continue their independence with their management. That's if they're conscious. If they're not conscious, then you so HbA1c. So healthy eating, regular exercise and weight control are some of the lifestyle measures that can help to manage blood sugar levels. And to assist in monitoring how the blood sugar levels are going, you may have heard of a blood test called HbA1c. So it refers to glycated hemoglobin, and it develops when hemoglobin, a protein within the red blood cells that carries oxygen throughout your body, joins with glucose in the blood and becomes glycated. By measuring glycated hemoglobin, clinicians are able to get an overall picture of what your average blood sugar levels have been over a period of weeks and months. It's usually 3 months, the red blood cell cycle. So for people with diabetes, this is important, as the higher the HbA1c, the greater risk of developing diabetes-related complications. So the higher the HbA1c is a direct indication of how often their blood sugar level is sitting at that level. So we finger prick, but it's that moment in time. So it's what that blood sugar level is at that time. Whereas this is an overall average of where their blood sugar level has been sitting for the 3 months prior to when they come and have that blood test. So it's an indicator of where their blood sugar levels are sitting. So 4.95, 6, so it's hard to read, 6.7, and then this one over here is 11.3. So this is saying that on average your blood sugar level is sitting at 11.3, and then a HbA1c of 5.8. On average your blood sugar level is sitting 6.7. So there's a little bit of a change down below. So 11 to 15. Does that make sense between the two? So somebody's blood glucose level is just what it is at that time, whereas the HbA1c is an average of where they're sitting over the 3 months. We'll just have a little look at some medications. In Australia, there are 7 classes of medications used to treat diabetes. I'm only going to look at 3 of them. So we'll look at these 3. So the buagonards, sulfonylureas, and the sodium glucose transporter, or SGLT2 inhibitors. DPP4 and the I can't even pronounce that, thiolidinones. We don't see them very much, the bottom 2 in Australia these days. We tend to see the top 3 much more. Older drugs. Yeah. And then there's some injections. So there's insulin. There's also another family of medications called Incretin mimetics, and they're not an insulin, but they are an injection and given the same way in a pen. We'll talk a little bit about those. So this is the most common, metformin extended release, or diformin, all the same tablet, just a different name. So different company, pharmaceutical company. So they help the body, in general terms, they help the body to be more sensitive to insulin. So they don't produce any more insulin, they don't get the body to produce any more insulin, they just make the body more sensitive to its own production of insulin. So it uses it a little bit better. Sulfonylureas, or glycoside, is the main one that you'll see, and it stimulates the pancreas to release more insulin. So it can contribute to hypoglycemia, a good way probably to start is, have you looked at what insulin is? So insulin, so we eat, and this is another way that I explain it to people living with diabetes. So you eat, and then the carbohydrate that you eat goes into the body as sugar, and insulin unlocks the cells that can use that sugar for energy. Yeah, so the more insulin you have, the more cells get unlocked, the more sugar gets used. If you don't have insulin, the cells don't get unlocked, and the sugar stays circulating in your blood. SGLT2 inhibitors, these are a relatively new family of medications, so probably the last couple of years. Canagliflozin, dapagliflozin, empagliflozin. You'd think they'd think of easier names, really. And their action is to inhibit or stop the kidneys from absorbing glucose from the blood, and then that sugar or glucose then leaves the body via urine. So we have, as people, we just have an automatic mechanism in our body that lets a certain amount of sugar out in our urine, and this overrides that, so more sugar gets pushed out. This one has a weight loss as well, so that's probably why it's becoming a sort of one of the more common or popular medications for patients to be prescribed. One of the side effects with this one, so the side effects with metformin, the general side effects, some people get a little bit of nausea or diarrhea at the higher doses. Sulfonylureas, it's usually, they contribute a little bit more with the hypo, so if people are having hypos, they tend to stop that medication. And the SGLT2s, because there's more sugar being pushed out in your urine, a really sugary, warm environment is a great place for infections or bugs, so urinary tract infections and genital thrush are the big side effects with these ones. The Incretin, so exenatide or liraglutide. So these were probably maybe 5 or 6 years old. A couple of them are being prescribed not just in diabetes, but also in obesity, for people for the treatment of obesity. So they stimulate the pancreas to release insulin, but only when the blood sugar levels are high. They reduce the amount of glucose released in the bloodstream by the liver. This is the big one. So they slow down gastric emptying. They make you feel full because it's slower rate of digestion. And then they have a little bit of an impact on the appetite receptors in your brain. So the way that we describe these family of medications are, it'll slow the rate that you digest food, you'll feel fuller for longer, and then your body will be able to, so it'll digest the food, but your blood sugar, your body will be able to keep up with the digestion after the meal, so help to keep your blood sugar level not getting as high. Because you feel fuller for longer, you won't eat as much. They don't tend to. Yeah. It's more, but it's definitely, I wouldn't say, it's not one of the main ones, but nausea, vomiting, feeling bloated are the main side effects. So because you feel fuller for longer, you eat less and you have a weight loss. They're either given once per day, twice per day, or once per week, depending on the brand of medication that you use. Exenatide has 2 forms of it. So a faster acting and a longer acting once a week injection. So it just depends on tolerability for some people. We're doing a new study actually, so I've got there's one, these ones are targeting one hormone in the gut. So the newer medication that they're looking at is 2 hormones in the gut. So we've got a study at the moment so the research looks like it's got a little bit of a higher weight loss, obviously because it's probably a little bit more potent in terms of that. The downside to that would be that maybe the side effects, so they're looking at side effects for that newer medication. And then there's insulin. So it's naturally produced in the body by the beta cells of the pancreas. It allows the glucose to enter the body cells where it's used for energy, and it also allows for excess glucose to be stored in the liver for later use. and a small amount of insulin is released from the pancreas into the bloodstream throughout the day when food is eaten. So without insulin, you don't do this. So that's why with type 1 diabetes, and we'll look at that in a little bit more detail. Do you want to have a break and do something active? So I've got how many have we got? Maybe groups of 4, 3 or 4. So I've got one group here where you can, are they allowed to test their own blood sugar level?
If they want to.
If you want to. So if you want to, there's a single finger prick. I just didn't bring cotton wool. You got
Or a tissue, I'll get something downstairs.
if you don't want to test your own blood sugar level, there's control solutions. So you can just tip a bit of control solution. Remember, if you've just eaten, that your blood sugar level might be high. It's not within 2 hours. And I'm not doing any like go and see your GP.
We are doing it tomorrow, so
Are they?
so I don't know.
No, they can do it.
You
Have
know?
a practice, and then are they getting
You wanna
assessed
have a go?
tomorrow?
Sorry?
Are they getting assessed? Or
No,
they're
no.
Oh.
Just doing it.
Just doing a look at
Anyone
it.
want to have a go?
The other one is so you can give so I've got 2, but these are the Bietapens. So they come in 5 or 10 milligrams. So it's just for you to have a little look at more than anything. Follow the arrow to upload it. But this is a water pen to practice. So you can put a little tip on. This one goes around your tummy. So we give injection in the tummy, and then just have a go with giving it to you. There's a sharps container over there, so I'll bring that over. And this one here, so I want you to think about, bring a pen when you come to this group. So this is a little book. So when we give insulin, and we'll talk about it a little bit later, they usually have a conversion that they use. It's usually 1 unit, so let's say 1 unit for every 15 grams of carbohydrate. So I want you to think of your breakfast or your dinner that you had last night. Write it down, use the book to look it up, see how many carbohydrates you had, and then see how much insulin you would have had to have given. Right, so I had a bowl, so if you have a bowl of cereal, you look up cereal. If you had 3 beers, you can look up BB. That's a good little book that they use. It comes in an app form, so loads of people have it just on their phone in an app. Alright, so do you want to get in the 3 groups? Probably let's use about 15, have a 15-minute break, and then I'll finish off.